Okay, the first recording something happened, so I'm recording again and I'm splitting module 29 into the concept 29 on self and exemplar 29A, eating disorders, and then a separate recording will be 29B, personality disorders, because the other is just too long. Okay, so concept of self. Self includes all personality traits, characteristics, beliefs, behaviors, includes overall self-image and self-perception, your body sensation, emotion, thoughts, conscious awareness. Um, it's difficult to talk about a normal uh, self-awareness. It's more of a healthiness. It's a dynamic process, it develops throughout our life as a result of interpersonal interactions. So, interrelationship components of self-concept. It's a personal perception formed in response to interactions with people and environment over our lifetime. Affects individuals mentally, physically, and spiritually. Effective nursing care is assessing patient self-concept, assisting them in developing healthy, positive self-perception. That does not mean we tell them and always give them, it's more giving them positive feedback and encourage their expression and guiding more of their development and expression of their self-concept. Self-concept, or also we as a nurses need to take responsibility for exploring and optimizing our own self-concept. Personal identity. Ideal self is a person with qualities and individual beliefs he should possess as well as those he aspires to develop. A real self is our perceived true self, and our public self is how the individual wishes to be perceived by others. This is all on page 1976. A personal identity. Objective is, of course, your name and age. Objective, not subjective. Cultural background, ethnicity, values, beliefs, self-expectations. Body image. Table 29.1 is a nice little chart on body image, and I broke up and took the key pieces. Perceptual is your mental imaging, cognitive is belief and attitudes, behavioral is behavior manifestations, affective is feelings about one's body, subjective satisfaction is your degree of satisfaction. Very, very clear, precise there for you. And this is an individual's mental picture of physical self, appearance, size of body, emotional reaction to those perceptions. Nursing comes in here very important with prosthetic devices and assistive devices because that affects body image and guiding a patient in learning their new body image and acceptance of it. Role performance. Page 1977, a role encompasses a grouping of behavior expectations associated with specified social or organizational positions. So, a group of behavior expectations so as students, nursing students, there are expectations as a student, expectations as a nursing student, expectations in your different environments as a student. Role performance, demonstration of behaviors or actions associated with your given role. Role development, teaching and modeling needed for role behavior includes socialization of individual preparing for a role, which is a huge job of the nursing faculty in your role development. Role ambiguity, lack of clarity about expectations, behaviors, or demands of role, which hopefully you are not having as a student. Hopefully we are giving you clear guidelines. Role strain is feeling not capable of fulfilling a role, which I think all nursing students go through, and then you get to that level and then you strain again and you get to the next level. Conflicts, expectations clash or incongruent, they clash, so they can be interpersonal. What occurs when individuals hold varying or conflicting expectations about tasks and behaviors with a specific role. It can be a husband and wife conflicting over expectations. It can be in multiple things when you're working as what your manager expects of you and what you thought was expected of you. Inter-role conflict occurs when roles create competing demands. As a student, you're the role as a student, your role as a wife, a spouse. You may have the role in your job, your role as a child, parent, sibling, multiple roles, and sometimes there's a conflict. Person role occurs when a person's expectations are in opposition to the values and beliefs of the one who fills the role. That can be very hard, where you're asked to do something that is out of what you believe. Role mastery, behaviors meet or exceed predetermined expectations, which you will be by this time next year. Okay. Self-esteem, what is it? Self-esteem refers to the way we see and think about ourselves. It's separate from our self-concept. It's our individual opinion of ourselves. Degree to which a person approves of, values, or likes themselves. It's their judgments about their self-concept. The categories of global is the whole thing, their overall whole well-being. And specific is regard to certain aspects like their parental, individuals' positive regard for certain aspects of themselves. The influence of this are parental nurturing. We can help them get a great self-esteem, or we can be overprotective and they do not have trust in themselves and see themselves as lesser. Perceived experience of rejection also lead to lower self-esteem. Let's see, in studies, individuals between the ages of 14 and 30 are high risk-taking behaviors, low sense of mastery, and poor health status effectively predicted lower levels of self-esteem. In older adults, self-esteem was higher among individuals who had completed more education. Self-awareness. I'm looking in the text. Self-esteem. Oh, self-awareness, right in front of me, page 1978. A formation of reality-based perception of yourself. It's an ongoing process where we have self-examine, we get insight into ourselves, we inspect, introspect our beliefs, our values, includes identifying relationships and connections to ourselves, and the outside perceptions, understands why we do what we do, shaped by how people perceive us, and actions are linked to our core values. Psychosocial development should have covered in your psychological development class and in pediatrics, especially with your, Erickson's. Newborns, lack of trust, confidence can result in anxiety. Lack of trust and confidence can result in anxiety, insecurity, and uneasiness. Early experiences of attachment can affect relationships later in life. That's why we're going to get into the problems of personality disorders, which may be greatly impacted by their childhood. Toddlers, asserting independence. Anybody who has kids, been around kids, the terrible twos, trying threes, frustrating fours, then you finally get to the fabulous fives when they're out of the toddlers. Developing skills, autonomy. The parent's role is to foster independence and avoid criticizing failures. Preschoolers, regular interaction with other children gives them an opportunity for interpersonal skills, sense of initiative, ability to lead, make decisions, develop a consciousness and self-control. School age, begin to understand how their actions affect others. Adolescence, re-examination of personal identity. Failure to establish sense of identity within society can lead to role confusion. Adults, low risk-taking behaviors and a high sense of mastery. Better health status is predicted with a higher educational level. Okay, exemplar 29A, eating disorders. So when I go into this, you're going to see your concept in 29 has some of these listed here. Where are we? So like 29.2, characteristics of common eating disorders is a really good table on 1983. So we will pop back into that as we're going through this. Eating disorders stem from social, cultural, and/or psychological causes. They produce a biological, physiological disruption in metabolism, not defined by body weight, external appearance, but by a psychological state that gives them rise to inadequate nutrition. Notice it's inadequate nutrition. That does not necessarily mean they are underweight. You can be obese and malnourished. How did I get to pathos? Oh, yes, I'm on the right page. Okay. Pathophysiology, hormones, brain chemicals, genetic causes can cause individuals to push themselves to starvation or obesity. These studies on anorexia nervosa, bulimia nervosa, and binge eating disorder estimate that 40 to 60% have to do with some sort of genetic factor. Regulation of feeding behavior involves complex integrative central and peripheral signaling network with positive and negative feedback. Research has shown that in comparison to individuals without weight issues, those with feeding and eating disorders experience blunted or attenuated functioning in both short and long-acting signaling processes responsible for appetite and weight reduction. And we just don't know what's the cause, what's the consequence of all of this. So that's good there. Risk factors. They said the origin is complex. It's a mix of multiple things. Genetics have shown that relatives of patients with feeding disorders are 5 to 10 times more likely to develop disorder. Neurological factors with your serotonin, norepinephrine, your dopamine. And of course, social. Women need to be thin, men need to be muscular. And it can be family systems where the family allows this maladaptive behavior. It can also be a result of sexual abuse, maladaptive coping. And as a result of diagnosis, parents may become overprotective and food can take on extreme importance, which will impact this more. Cognitive behavioral theorists say that feeding and eating is seen as a learned pattern based on irrational thoughts and beliefs. Anorexia nervosa. It's on page 1993. Also back in earlier in here, characteristics, manifestations on page 1981 and 1983. So I'm going to bounce between these. Diagnostic criteria: intense fear of weight gain, refusal to maintain healthy weight, and distorted body image. Potentially life-threatening, especially cardiac. Compels individuals to lose more weight than is healthy for their age or height. More common in Caucasian females. Highest mortality rate is of any mental illness due to complications of malnutrition and high suicide rate. It's a psychological disorder because they look in the mirror and they see fat. They can't see what's actually in front of them. A healthy BMI is 18.5 to 24.9, so underweight is considered under 18.5. Anorexia, there's a box 29.1 on page 1993, mild is a BMI of under 18.5, but at least 17. So just think of mild, normal as 18, mild as 17, moderate as 16, severe as 15, and extreme less than 15. It's the easiest way to do this. Their additional behaviors limit food consumption, often consumption with excessive exercise, refuse to eat in presence of others, cutting food in small pieces while pretending to eat. The self-induced vomiting and laxatives tend to be more on the bulimia side, although anorexics may do that in addition to just plain not eating. Hospitalization criteria is also in that box 29.1 with this severe BMI, severe anorexia with a BMI under 16 in that 15 range. Arrhythmias, because it's affecting their heart, systolic blood pressure and heart rate are not adequate for health. Clinical manifestations, this is also on page, and your table on page 1983. Does really good of having your manifestations and your treatment. Also table 29.2. Obsessive focus, those are your characteristics, are your manifestations for eating disorders. Let's see here. Sorry. The picture on page 1994, it affects from head to toes, brittle nails, yellowing skin, this lanugo, the hair, baby hair forming where there normally wasn't hair, feeling cold, low blood pressure and heart rate, arrhythmias, brittle bones, changes in the brain causing like a brain fog and impaired cognition and depression. What's the difference between anorexia nervosa and anorexia athletica? That's back on page 1992. There's a mention of that. I'm trying to find it. Patient teaching on page 1992, sports and eating disorders. Read over that for these signs if you ever end up working as a school nurse at any level. This is something to be very familiar with on condition which individuals seek a lean body type, engage in excessive exercise and calorie restrictions, and it becomes compulsive and competitive. Clinical therapies and diagnostic tests. I have listed here your antidepressants. If you look back also, page 1983, you have different disorders and your therapies to the right, antidepressants, cognitive therapy, group therapy, family therapy. You check an albumin, total protein, because those are your protein factors in your blood. Electrolytes, that's your BMP, basic metabolic panel, which is your glucose, sodium and chloride, BUN and creatinine, bicarb, which is your CO2. What am I forgetting? Sodium, chloride, glucose. Sodium, chloride, potassium, BUN, creatinine, glucose, and CO2. 7. Okay. Then your kidney function is your BUN, creatinine. Your liver function is in your complete metabolic panel, not your BMP. That's your AST and ALT, maybe your bilirubin. Your thyroid, that's your TSH, thyroid stimulating hormone, and thyroid hormones. Complete blood count, looking at your white blood count, RBC, hemoglobin, hematocrit, and your platelets. Your analysis, you're looking at your specific gravity for hydration, bilirubin, spilling glucose, spilling proteins, and especially spilling ketones, which means you're breaking down muscle. That's a malnourishment. Bone density because of loss of calcium and bone fractures, stress fractures. Electrocardium for your cardiac arrhythmias and cardiac function. So treatment, the Maudley phase on page 1998. Yes, Maudley approach. It has 20 sessions in total. It's particularly effective in adolescents with anorexia. It is the stages where the parents have to be involved. Parents in charge of weight restoration. They hand the second phase 2. Then they give the control back to the adolescent. In phase 3, they discuss adolescent developmental issues. So parents are in the first part, then the adolescent takes control, and then they work on developmental issues on the third Maudley approach. Now we're going to go into bulimia nervosa, page 1995. Oh, there it is. There's a table 1996. That's what I was looking for before, where you have your manifestations and your clinical therapies of each. An excellent study tool there. Bulimia nervosa is the binge eating followed by purging. They induce vomiting or they use laxatives or both. Many have both anorexia nervosa and bulimia nervosa. They might include extreme exercise. Often with bulimia nervosa, this may be missed because they have a normal weight or even overweight, but they have an eating disorder. Females 10 times more likely than men. Anorexia nervosa is more common. It's in 3% of the population and often coexists with a mood disorder, anxiety, or substance disorder, or all of the above. Diagnosis: binge eating in association with unhealthy compensatory behaviors at least once a week over a 3-month period. Purging is removal of fluid from the body, such as self-induced vomiting. Enemas of diuretics can lead to dehydration and alterations in body electrolytes. Interesting thing on evidence-based practice on page 1997, feeding and even eating disorders and the internet. 92% of teens report daily internet use, with more than half online several times a day. It's just impacting how they see themselves and their expectations. Is it bulimia? Yes, and for bulimia, the only FDA approved antidepressant or SSRI for bulimia is fluoxetine or Prozac. Indicators of bulimia nervosa are menstrual irregularities, because your hormones are out, depressed mood, unexpected stomach pain, unexplained damage to teeth, scarring, backs of fingers, toxicity from chronic ingestion of Ipecac to induce vomiting, cardiac arrhythmias, low blood pressure, low heart rate, electrolyte disturbances, bloating, and slow peristalsis. I mean, it can lead to major problems. So here, physical signs as a nurse of things you need to look for, especially in adolescents and early teens: cavities and gum infections, worn teeth, enamel, broken blood vessels and eyes, dry mouth, pouch-like cheeks, rashes and pimples, cuts and calluses on fingers. I have seen those calluses. Electrolyte imbalances. These are things because they're putting their hand in their mouth to cause the vomiting. Clinical therapies, again, that's listed on your table in 1996. Antidepressants. Remember I said the only antidepressant FDA approved for bulimia right now is your fluoxetine or Prozac. Cognitive behavior therapy, family therapy, dental exams, electrolytes, cardiac eval, and gallbladder, because of a lot of the ways their food's digested and bilirubin getting elevated. Next is your binge eating disorder. That's also in the bottom of that table in 1996. And binge eating on the bottom of page 1995. Rapid food consumption with inability to stop may keep eating long after satiety. No specific test or diagnosis. Complications can be obesity and extreme weight gain, high cholesterol, type 2 diabetes, and heart disease because of the excessive eating. Clinical therapies, antidepressants. Oh, I'm going to go back a minute here. Hang on. In the chart on page 1996, binging once a week for at least 3 months, absence of purging, sense of loss of control, allowing eating and weight to interfere with personal relationships, sense of embarrassment and disgust after overeating. I worked with a nurse practitioner that had a binge eating disorder, and it was very stressful for her. Clinical therapies, antidepressants, cognitive behavior therapy, physical exams, looking for heart problems and gallbladder disease, blood and urine tests, psychological evaluations, just like in any of the other eating disorders. Nocturnal sleep-related eating disorder is a little blurb in here. Gosh, where are you? It's back in the concept itself on page 1981. 1981, yes. Right under the chart on 29.2, nocturnal sleep-related eating disorder characterized by an initial period of insomnia, followed by sleepwalking, in which the person consumes unusual foods. These unusual foods I'm going to talk about in a minute, and it typically starts in the personal 20s, obesity, difficult losing weight because they're eating when they don't even know they're eating, referral to nutritionists, evaluation of mood and stress, screening for sleep-related disorders. It is often associated with a sleeping pill, Zolpidem, which is Ambien. It only lasts like about 4 hours, so they will sleepwalk as it's wearing off and do some very odd things. They used it a lot in the Army, and we saw some odd behaviors with it. So here, with eating odd things, is called pica, consuming non-nutritive, non-food substances such as chalk, paper, dirt, metal, string, hair. More common in children, but it's also part of this nocturnal eating disorder. It can occur also in pregnancy and in adults with intellectual disability or mental disorders. Nursing diagnoses, I'm not going to go over. You can read these yourself. They're in your text in page 2001. Just remember when you're doing your things that you have an assessment that matches a diagnosis that matches your implementation, your planning, implementation, and goals, outcomes need to all match and come together. So your implementation is safety, preventing injury. Behavioral contracts, just like you have a safety plan contract, you have behavioral contracts. They're very effective, but it has to be the patient's decision of what will go into that contract. Teach patient to decrease exposure to stress, limit their caffeine and stimulants, increase social family connectedness to improve communication skills, teach methods for self-soothing, whether it be a book, music, scents, baths with beads or oils in it, self-soothing. Encourage patient to eliminate drugs, alcohol, which can increase impulsivity because they've got an eating disorder. To transition out of this disorder, they have to be courageous. They have to have a trusting relationship with their health care provider, and have realistic goals.